I want to thank all the viewers today, and I want to thank my guest especially. Guest today's Kurt Miceli. Now, I met Kurt a few days ago at a couple of events, actually at the America First Policy Institute, where he spoke, and also at the GenSpect Detransition Day Awareness Day event. And I really got interested in what he had to say. So let me give you a real short bio. Dr. Kurt P. Miceli, MD, MBA, is a board-certified psychiatrist and internal medicine physician, respected educator and accomplished healthcare leader known for his integrated approach to complex behavioral health needs and his commitment to excellence in medicine. He earned his medical degree from Drexel University College of Medicine in 2003 and completed a combined residency in internal medicine and psychiatry at the University of Virginia Medical Center. He later obtained his MBA from the University of Virginia Darden School of Business, blending deep clinical expertise with strategic business insight. With more than 2 decades of experience, Dr. Miceli is focused on compassionate, high-quality care for individuals with autism, intellectual and developmental disabilities, and severe mental illnesses. He founded and served as president of Marcroft Medical Associates, a specialized practice providing psychiatric, behavioral health, and neurological services. His executive leadership has included roles as senior vice president at Elwyn, from 2018 to 2024, and Senior Vice President and Medical Director at Bancroft from 2015 to 2018, where he advanced quality improvement and innovative behavioral health programs. Dr. Miceli is an assistant professor in the Department of Psychiatry at Drexel University College of Medicine and currently serves as Chief Medical Officer of Do No Harm, where he advocates for merit-based standards, integrity, and patient-centered excellence in healthcare. He is also a dedicated educator who has taught healthcare economics for a number of years in Villanova University's MBA program. With warmth, intellectual rigor, and an unwavering dedication to both his patients and the future of medicine, Dr. Miceli continues to bridge clinical practice, leadership, and education, making meaningful contributions to psychiatry and the broader healthcare landscape. Welcome to the podcast, Dr. Miceli.
I appreciate it. Thanks for having me, Mike.
For our listeners, you're a psychiatrist with over 20 years of experience. As an assistant professor at Drexel University College of Medicine and the medical director at Do No Harm, an organization dedicated to safeguarding medicine from ideological influences. Today, we'll dive into your work, your views on current challenges in healthcare, and the future in the field. Let's get started.
Sounds good.
Can you start by sharing a bit about your journey into psychiatry? What inspired you to pursue medicine? And how did your experiences in residency and practice shape your perspective on patient care?
Oh, great question. And gets me to reminisce about some fond moments from the past. And that was with my uncle. My uncle Anthony was an ear, nose, and throat physician in Staten Island, New York. And he loved his job. He loved everything that he did. He loved the patients. He loved working in the hospital system, working in the clinic. And I guess that love really resonated with me. It's like, wow, he's helping people. He's having such an impact. This is something I would love to do myself. And certainly my parents, who had worked in a florist center and also did some banking work and such. They're like, yeah, go into medicine. Medicine is the way to go. Your uncle is doing great. And he practiced during the quote unquote golden age of medicine, so to speak. And so I pursued this career and this idea and was very fortunate to get into a program that Villanova University had with Drexel University College of Medicine. And so in some sense, it was a combined program, doing college and then going on to medical school. And it just really, it opened my eyes as I continued that process. And I became more and more interested. And I suppose my parents' dream was that I'd do an ear, nose, and throat fellowship and such, and go on to take over my uncle's practice. But what turned out is that I was really interested in psychiatry. The month that I spent in my third year of medical school on the clerkship that we had for psychiatry was at the Eastern Pennsylvania Pennsylvania Psychiatric Institute, which is now closed. But there were skeleton keys, and it was almost as if it was from One Flew Out of the Cuckoo's Nest. And it horrified me, to be honest. It was really like, wow, this is not the way care should be. It needs to be different. It needs to be compassionate. It needs to be focused on patients. And it seemed too much like a movie. And granted, that it's probably a bit of a overgeneralization and such. There were many good people who worked there, many good things that were done. But at the same time, the initial impression just really made upon me that, wow, how can we do this differently? And then when I went to my family medicine clerkship, I saw that psychiatry is not just confined to the halls of the inpatient psych unit. It's everywhere, right? Our behavioral health is everywhere, and it impacts how we operate, who we are. And frankly, I think I came to realize it was probably why I was interested in economics, because that was sort of the study of behavior, just what people did in terms of their monetary choices. This was behavior, obviously, in psychiatry, our mental health and such. So it all was in this behavioral framework, and it just had me just absolutely fascinated. And so I pursued residency, did an internal medicine and psychiatry residency, because I thought it was just so important to get both of those aspects of understanding the medical illness and the psychiatric illness. And I know we kind of bifurcate them in medicine, but really they're connected. And there's so many examples within medicine where medical illness per se has psychiatric manifestations, or psychiatric illness can cause medical problems. So, these really are intertwined, much as the body is intertwined, right? The heart and the brain don't operate in isolation, where it's all connected. And so that part of medicine really attracted me. And certainly my career then took me to working in the outpatient world, and to working in crisis centers, to work doing some inpatient work, and then ultimately working with folks with intellectual developmental disabilities. I always had a desire to see, hey, what can we do to really help systems, help physicians, leadership within medicine, and really fell in love with folks with intellectual developmental disabilities, wonderful folks that we would be able to treat in a home environment. It allowed some continuity of care because they lived in the human service organization. And so you really got to follow folks and not just have folks in a hospital for 5, 7, 10 days. You got to understand who they were over time. And that was the beautiful part of psychiatry and of medicine, of getting to know people, to understand them, to learn from them, in fact, and really experience the journey together as humans, and to be able to offer the advice and the knowledge that I had, while at the same time very much learning from the individuals themselves. So it's been a very fortunate journey, and certainly at this point, I've been with Do No Harm for a year now, and I suppose we'll get into, well, and if you loved it so much, what happened? Why did you sort of move into a different space? And I do believe they are connected, partly because of this idea of the culture of medicine. And unfortunately, there's been a lot of change in the culture of medicine, where that golden age isn't quite there. The patients are there. There's the relationship you can have, but there's so much that we need to do to really help the culture be what it needs to be, and for medicine to be what it can be to each and every individual.
Thank you so much. As a medical director of Do No Harm, what is the core mission of the organization, and how did you become involved? Can you give an example of how identity politics or DEI initiatives are impacting medical education and practice today?
So I suppose this gets into that journey, the detour that I took, and it was really as an administrator within Human Services and within Elwyn. And again, I think the organization did some absolutely wonderful work with folks in many, many ways. But what I started seeing as I got into sort of the administrative realm were some of the contracts, the payer contracts, and sort of the business side of medicine. And I even would deal with insurance companies in various degrees, and we would provide them with program descriptions for the various programs that we operated. And I recall one time where one of our program descriptions was reviewed for quality, which was totally normal and appropriate. However, the response that came back was really not a critique of quality, but a critique of the pronouns that we used. And so we had used he and she, and the desire of the insurance company was to use they and them. And they pointed us to their language guide that they have online about sort of the outdated language that we were using. And this was the quality assessment. There was really no other indication of anything that we did. It was purely a pronoun critique. And it struck me some years ago as, wow, this is just insane. They're not focused at all on the quality. And it struck me as curious. And it really started to present a conflict as an administrator as to, well, what do you do? Do you go along with it, or do you fight it? And what I learned is that it's hard to fight insurance companies, certainly from the point of the provider who relies on that insurance company to do the work that you were intending to do in serving people. And that was a point of challenge and strife for me. And I'll also say that COVID obviously had occurred, as we've all experienced, and that was another, I guess, point of challenge and strife in the sense of just some of the regulatory behaviors that had occurred in terms of not allowing people to work who had not been vaccinated, and just some of the things that became a little bit more challenging, certainly for a human services provider that dealt with tremendous turnover and had people work for an entire year unvaccinated, working their hearts out to help individuals. And certainly, we obviously did everything we could to protect the individuals that were in our care by getting them vaccinated and offering that to them as they accepted. But these little things started to become more and more significant. And, one day I ended up going to the Mutter Museum in Philadelphia, which is a wonderful museum. It has it's a museum of medical marvels and mysteries, and had originally been donated by someone who had been in Philadelphia back, I think, in the 1850s. It was a surgeon who had a collection of just various medical ailments that he had gotten acquired in his collection to teach medical students about human anatomy, physiology, and the like. And so that has been preserved in this museum, which is very much a Victorian-style museum. There's a sliver of Albert Einstein's brain. There is a skull of someone who has Marfan syndrome. There's a casting of Siamese twins. It's really remarkable. And this is run by an organization that was founded in, I believe, 1787. So effectively as old as the United States, that operates the Mutter Museum. But the first thing that I saw when I walked in, and didn't even get to the museum yet, was a Black Lives Matter flag. And it struck me as to, here is a museum that is aiming to not be political, but just to really be a embodiment of medicine, the history of medicine, the how disease has progressed and what we've done in terms of treatments and such. But yet it's starting out immediately with a political message. And so I did some Googling because I was just curious what's going on here. And I stumbled upon an editorial, an op-ed that Stan Goldfarb, Do No Harm's founder, had written about the wokeness of the Mutter Museum. And it really spoke to me because, again, I saw this museum and thought, wow, this is just an incredible organization, incredible activity. But yet it was just sort of draped over with this political taint, and that really bothered me, and that was sort of what got me interested in Do No Harm, because here was an organization now of over 50,000 members that was taking a stand to say, identity politics needs to be out of medicine. And we need to focus medicine on quality and on patient care, on doing what's right, and not be sort of trapped by DEI and other sorts of political ideology. And frankly, that's one of the reasons why Do No Harm has also taken upon itself as one of many organizations that's fighting really the tyranny of gender ideology and how it's harmed kids. So that's been our focal point at Do No Harm, and it was very much a mission that attracted me because, certainly healthcare has lots of challenges. There's no doubt, whether it's the payers, the insurance, it has plenty of challenges. But if we don't get the culture right, if we don't get the trust, the relationship between doctor and patient right, we're just not going to have a healthcare system that people have confidence in, that people are going to utilize, that people are going to benefit from. And that's just, that really bothered me. And it bothered me so significantly. And particularly as these little things were becoming more and more frequent at my own place of work, where I felt like I was almost in some ways powerless to change things because they were being imposed from even outside the organization. So not even from within the organization, but from outside of it, perhaps from the halls of academia that were informing the insurance and how they would sort of push ideology into the clinical space. I thought something needed to be done, and it was becoming harder and harder for me to operate in good conscience as someone who was trying to steer the ship, help people, but at the same time, this ideology was just pounding at the door. So that's how I got involved, and certainly, Do No Harm has just done some incredible work in identifying these issues of identity politics in medicine and recognizing how divisive they are. One of the things that we often hear is sort of this motivation to make physicians into social justice warriors. And when medical education becomes about social justice warriors, we've really lost our agency. We're supposed to be training doctors to be outstanding physicians, to be competent in the care, to know how to treat hypertension and diabetes and depression and all the ailments that one may face. But instead, we've got all this other stuff going on as well in medical school. And again, it's partly how this gender ideology has creeped in and how activists have moved in. And I've seen it in medical organizations as well, whether it's the American Medical Association or the American Psychiatric Association or the American College of Physicians, where again, ideology has run rampant in some degree, and these organizations have moved well outside of the domain of any sort of degree of expertise into these social justice areas. And I think very much to the detriment of medicine. It's got to make people outside of medicine wonder, why is a medical organization talking about these other issues when there are plenty of issues within the healthcare space to focus on? And why are they, certainly now with everything that's come out on the gender ideology side with WPATH, why do they still push this ideology on kids and such? So I think there's just such an important piece of work that needs to be done to fix the culture of medicine, and that's the work that we're doing at Do No Harm, and others are doing it as well. And it's really an honor to be part of the movement to help do that, and ultimately to help patients get good quality care that doesn't have this political influence.
Wow, there were so many important points that you made in there, but one of the things that worries me is that it may be some ways it's deeper than ideologies. It seems that there's a flaw in human nature. There was a Latin term, I think it was libido dominandi. It's a lust for power and control over other people, and that seems to be something that we should be afraid of, because its history just keeps repeating itself with this kind of madness that we go through.
Yeah, well, and certainly you do see that in the very activist nature. And I've got to think that many of the physicians who are at these medical societies, again, I want to believe, I'm an optimist at heart, are reasonable, good people. And I think some of them may get trapped by that, because oftentimes the folks that you see accelerate within the medical societies are folks who might wish to be a dean of a school or wish to advance their career in some other ways. And so they might give a little to get along. And so activists, well, get their message moving forward, because folks are afraid to look like they might be racist or transphobic, whatever it might be, whatever the issue of the day is, and so consequently you sort of go along with these notions, and unfortunately, yeah, that's where we need to recognize, well, wait a second, let's pause, let's look at what we're actually saying, let's understand it, and let's have the appropriate response, not just continue to go along. And again, we've seen where that has done in the gender ideology space with kids and such. So I think it's yeah, unfortunately, there are many factors that are involved, and there's a lot of work to be done to help unwind that and get it to where it needs to be.
Very good. You've testified before committees on issues like DEI in medicine. From your viewpoint, what are the biggest risks of prioritizing diversity quotas over merit in medical training and hiring? How does this affect patient outcomes?
Wow. I'm just a believer that you want the best. And I think that's a belief that the vast majority of patients, if not all, have, right? That you want the absolute best in your doctor. You are going to them, you are trusting that they have been well trained, that they're the top of their class, that they are going to help you in a life and death moment, potentially. And certainly, I think any of us who's on the OR table or the gurney in the ER, you want to be confident that that person is there for all the right reasons. And again, there are many absolutely outstanding physicians that are there of all different races, colors, religions. It's just incredible to see the collection. And I think, unfortunately, when we also allow sort of this intrusion of DEI, it certainly hurts those who have earned their place there and need to be viewed as having earned it by the merit, not, oh, you're here because you're X, Y, and Z. That's just not right either. So we need to assure that the system is very clear that it is merit based, because again, we want the very best person to be caring for us, to be caring for our family members, and we want to instill that confidence within individuals. So that part of the meritocracy, again, I guess people often think of it, whether they're airline pilots or they're doctors, you want to be confident that you have the very best. And I think it's also important that we make sure that we are driving for excellence. There was an article in the New England Journal of Medicine, I believe it was last year, about this idea of P equals MD. Pass equals your medical degree as a physician, as a medical doctor, and the argument there was actually, well, that's a little concerning. Do you want everybody to sort of go down to the lowest common denominator and just pass,
Mhm.
or do you want everyone to be excellent? And yeah, there are going to be different shades and stripes, but the neurosurgeon, the some of these fields with such technical expertise, yeah, I think you look at the best of the best who might be part of that field, and if we're driving everyone to a P, well, that doesn't really help. And so we've unfortunately seen this. We've seen what happens, that if you look at step one of the boards here, the United States Medical Licensing Exam, it's now pass fail. That exam, when I was in medical school, was a graded exam, and that grade was often very much a significant factor in determining what residency you would get into, because schools, they would sort you based on your score. If you didn't meet a certain threshold, they might not interview you. And that was, again, because they're getting thousands and thousands of applications, right? So they need some sort of a mechanism to figure out, well, hey, who's really the cream of the crop that we want in our program or not? Well, it's pass fail now. So everybody who passes looks the same. And the other challenge is that grades in medical school for the first 2 years have gone to a pass fail modality. Now, not all schools have done that. There's still some schools that do ABC or pass, high pass, honors, and that sort of thing. But there are many schools that have gone to this pass modality. So now you have grades that you have pass or fail. You have a test pass fail. You can't tell who really should be the next neurosurgeon or not, and that's a real problem. And to see that the New England Journal of Medicine was able to have an article that articulated that, I thought was, wow. There's at least some positivity. There's there's a degree to be optimistic, because unfortunately many of these medical journals have in some degree circled the wagons to protect the DEI phenomenon, and to sort of push merit out. But I think the realization is that any reasonable person would understand that, yeah, well, yeah, don't you want your doctor to strive hard, to study hard, to be prepared, so that when you're there in the ER and have that emergency, they're going to be well equipped to care for you? So again, this is a reasonable person standard. This is not necessarily left or right. This is just common sense for what we want in our physicians, our providers, and such. And unfortunately, this is some of the repercussions that we've seen with DEI. And do no harm, we've aimed to track it. We have a Center for Accountability in Medicine that produced a medical excellence index to actually rate medical schools based on merit, based on whether they are dabbling in ideology, and hopefully not, and to provide a score, because we recognize that, yeah, there are other entities that score medical schools and rank colleges and universities and all that sort of stuff. But what are they looking at? Are they looking at research dollars that are funneling in, or are they looking at DEI offices? What are they looking at? And we know that with our index, it's very clear what we're looking at. We're looking at the MCAT scores. We're looking at whether grades are actually given, or if it's pass fail. We're looking at if they have a DEI office or not. We're looking at if they recognize the Medical Honor Society or not. And so we've got sort of the criteria to help elucidate, hey, which schools are focused on merit, focused on excellence, and which aren't. And of course, we salute those who are committed to excellence, and we challenge those who aren't to, hey, it's time to change course, and to really focus on what it means to provide excellent education so we can produce excellent physicians for tomorrow.
Well, it really struck me when you were speaking. I remember a day when our professors would post the exam results on a board outside
Hmm.
the classroom, and the competition drove people. Really,
Hmm.
it did. And now that would be impossible in today's day and age, because it would just blow the whole DEI thing out of the water.
Yeah.
Um,
Yeah. And
in,
it's hard
in
to believe that this is all a recent phenomenon, in the sense, I mean, I was in medical school just a little more than 20, 25 years ago, and yeah, we posted the grades, and so you saw it. But yeah, I think you're right. In this day and age, man, that would probably get the professor written up.
I think so. In recent years, there's been a lot of debate around gender affirming care for minors. Based on your expertise and the data you've referenced, such as surgeries on children in Pennsylvania, what concerns do you have about current approaches in transgender medicine?
Yeah, this has certainly been a challenge for the world, and certainly not just the United States. And one of the great concerns I have is sort of the rapid medicalization. I mean that sort of phenomenon of someone comes in, we look to put the round peg through the round hole, thinking that's what we're doing, and bam, you're off to the gender clinic, and that's really scary. And it's certainly scary as a psychiatrist because we should be taking the time to really understand and to assess and to really get to know the individual for who they are. And I think, unfortunately, the assessment process for many courses of illness has, in some ways, gone out the window. And we've allowed ourselves to be very much directed to provide these sort of short assessments, if even that, followed by 15-minute med checks. And we've created a system where we're not really getting to understand and know folks. And so, for one, we just need to step back and take time to truly assess and understand, because it may very well be that that individual doesn't have gender dysphoria, and maybe it's a comorbid condition such as autism or such that's causing one to view gender through a lens that might make them appear as if the diagnosis is gender dysphoria, but the reality is that it's not. It's just that they experience difference in a different way, and that we are hearing it as the clinicians very sort of in one fashion, as opposed to, hey, let's take a step back, let's understand the situation, let's speak to other family members, let's get the full history to be appropriate in our diagnostic assessment. The other side of it is just looking at the evidence. And I think that's been just a complete a challenge, because when you do look at systematic reviews and you understand the evidence, you see that it's a very low certainty that there's any degree of benefit, and there's significant impacts and cost. And so that needs to be understood as well, that, wow, should these procedures even be offered to minors? And certainly my argument would be no, because the evidence, the data just isn't there at all. And we also know that adolescents, children, aren't able to consent. And so when we allow a child to sort of have a child-driven model, we've effectively abdicated any professional responsibility as a physician. We've allowed this sort of idea of autonomy to guide everything, and we're placing that autonomy in the hands of someone who may not really grasp, well, what's it going to be like 10 years from now if I'm not able to breastfeed, or if I'm infertile, or if I've got metabolic issues because I'm taking X, Y, and Z, or my bone mineral density is osteopenic, or I have osteoporosis, whatever it might be. I mean, these complications that unfortunately are part and parcel to the nature of the medications or surgeries that may be given. Is a child or an adolescent truly able to comprehend what life would be like, or what they would desire to have a family, to their health, whatever it might be? Are they able to really put that in perspective? And I think many of us who even remember our own adolescence probably recall that we're just focused on today. We're not thinking maybe even a week out. We're let alone years out as to what that would be. So I think we've just got a multifactorial set of issues where we as the clinicians need to do much better in our assessment and our understanding of the individuals before us, to understand the comorbid psychiatric illness, the other complications, the trauma that they might be experiencing. We need to look at the evidence ourselves, because honestly, we can't trust the medical societies. I mean, many of them have just been allowed themselves to be hijacked by activists, and have pushed an ideology without looking at systematic reviews themselves. I think of the American Academy of Pediatrics, which said a couple of years ago was going to look at systematic reviews, and we haven't seen anything yet. Maybe that's still in the works. I like to be an optimist, but unfortunately, based on what we see, it's not hopeful. Certainly in the guidance and the position statements that they currently have. And so there's so much work to be done in making sure that we do review the evidence. HHS did a wonderful job in assessing that evidence, and certainly if folks have questions about that, well, you just need to go overseas and look at what the CAS review did. And if you have questions about that, you just need to go to Finland. And if you have questions about that, you can go to Sweden. You know, there are multiple countries that have done systematic reviews that have looked at the evidence and have come to the same conclusion. And it's again, of very low benefit, significant cost, significant consequences. And we see from even these progressive nations in Europe that have said that, hey, psychosocial support. We need to put the brakes on these hormones, puberty blockers, surgeries, focus on psychosocial support. And likewise, certainly what we know from the literature is oftentimes doing nothing allows folks to just naturally desist. That has traditionally been what we have seen with gender dysphoria in terms of what happens as the natural course of the condition. And so, unfortunately, we may be medicalizing folks in some ways by the gender clinics and almost supply creating its own demand, which is obviously problematic in its own right. And again, it's incumbent upon the clinicians to be those professional experts to look at things not just through the lens of autonomy, but to remember that we have really four key ethical principles in medicine, and one of them is beneficence, doing what is right for the patient, and understanding that one is doing no harm, an absolute key principle, and then the idea of justice as well, which is critical. So I think those are the three sort of buckets that I would look at, and unfortunately, by ignoring the evidence, by just focusing on autonomy, we have just led ourselves by doing really brief, if anything, assessments. We've led ourselves to a path where kids, unfortunately, have been very quickly medicalized, and there's been significant harm. And certainly, having met you at D-Trans Awareness Day and meeting other detransitioners or meeting the detransitioners who were there, just hearing their story and their courage, it speaks volumes. And it makes me cringe and embarrassed to say that I'm a medical professional, because I just sort of feel the profession has just done so many wrongs, and we've got to do right, certainly by individuals who have been harmed by the medical system, to make sure that they can get the care that they need, the justice they deserve, to make sure that they can live full and healthy lives. And unfortunately, the medical system has done much to harm that. And so it's great to see that courage of detransitioners coming together, hearing their stories. They're important. It's so important for someone like myself to hear. It's so important for other clinicians to hear as well. And so we just need to keep amplifying that voice and making sure this message gets out, so we can do right, and we can put these wrongs and really make sure that we end these practices. And there's a lot of work still to be done, but we continue to do it. And I'm certainly encouraged by many of the folks that I've met and the organizations and what they are doing to end the madness of gender affirming care in kids.
Amazing. What really struck me there was, in order to regain trust, you have to return to your core fundamental principles of medicine. So I wholeheartedly agree with you. But what does it say about our culture when we just ignore these rigorous, 400-page evidence-based, it's madness. Like there's so much evidence against us, but it goes on. It continues to this day. We've allowed these ideologue physicians to put their own will above the patient's interest.
Yeah. Yeah, it's really it's shameful. And unfortunately, medicine, as you said, history repeats itself. Medicine is not innocent. It's done bad things in the past before, and granted, it's done many good things as well. But there certainly are elements and times in the course of history. Certainly, working with folks with intellectual developmental disabilities. The eugenics and sort of the movements of late 1800s and early 1900s. Yeah, they have done terrible damage to medicine, and here we are today with the issue of our time, and it's important for us to really make sure that this does end. And you're right, this idea of trust is so key, because if you can't trust your physician to have your best interest at heart, to provide professional guidance, not just to sort of be this sort of fast food restaurant, have it your way. No, we're not Burger King. We're not McDonald's. We are aimed and need to be professional folks that people are coming to for the knowledge that we've gained, the experiences that we've had, to do the right thing and to do no harm.
And I think that's going to be pretty much impossible to happen unless we go back to a system where the independent physicians, where they're not controlled by some central board or planning authority or the government or Medicaid or Medicare. That's the thing. It's impossible for a hospital to run independently without Medicaid or Medicare, right?
Yeah.
They can't do it. I don't know of any hospital that doesn't,
Yeah, and those would be wow, few and far between if they even existed in that frame. And it's but your point is certainly well taken, because what we have seen is the rise of the conglomerate and the decline of the private physician, and certainly many physicians who graduated in my class and those who graduate now, they look for employment. They don't look to put their shingle out. Very different from what my uncle did, who put his own shingle out. His reputation was there, and if he
So you're
didn't do
free.
well,
You're free to do whatever you feel is right.
yeah, yeah, yeah. It's a different construct that we're in today. So, as I said, many issues in medicine. There are a lot to tackle, and I hope we can start by getting the culture piece right, so we continue to drive some positive change.
All right, let's jump into the next question here. Shifting to broader psychiatry topics, how has the mental health landscape changed since you started your career? With rising rates of anxiety and depression, especially post pandemic, what role do you see for psychiatrists in addressing societal factors like social media or cultural shifts?
Yeah, it's I think unfortunately the we have come to a very different point as we've moved forward. It used to be decades and decades ago that if you went to a psychiatrist, it was taboo. It was something of shame and such. And I think in some degree that's almost flipped on its head, where maybe it's a badge of honor in some respects. I often hear people proudly talk about their diagnosis or the medication that they're on. And granted, that's anecdotal, and that's in a setting with a psychiatrist, so it might be in some sense giving me what someone may perceive I want to hear. But that's something that always concerns me, because I think, yeah, the Diagnostic Statistics Manual, the DSM, it's a lexicon, and it's not perfect by any means, but it certainly at least allows some degree of ability to communicate. But I would hate for folks to attach themselves to labels so strongly that it becomes almost part of their identity. People are people. You're the individual. You're a beautiful person, and we should treasure that in you, and not these labels that get just so bantered about so easily and such. So that's the part that often would trouble me. And certainly in the clinical setting, I would often want to make sure that when I'm speaking to someone, that yeah, this might be the term that we use, but I recognize you as the individual for who you are. And sometimes even the medical language, you talk about the depressed patient, or the autistic patient. Well, it is, I suppose, someone who has depression. It is still that individual. It's Johnny or Mary or whoever it might be. And so that part of, I think the medicalization is of concern. And then the idea that folks always want a quick fix, that, hey, I got anxiety, so I need this, and I got this, so I need that. And I think oftentimes what much of the system has moved us and accelerated us towards is this medical model. And yeah, there's some medications that can certainly be beneficial, but maybe there are other things that can be done as well. And maybe there's actually time that we need to spend in the psychotherapeutic setting in terms of helping to understand someone, to work through issues, to truly be able to gain skills that one needs to help navigate life. Because we all will encounter stress and strife, and perhaps some of this is, from the pharmaceutical industry, in the sense of wanting to promote drugs, and so everything gets a label, and if you have the label, you get the drug, and such. But it's incumbent upon the physician again to provide that professional judgment and that expertise. I suppose some could argue, well, that's beneficial for the person who's struggling in their home and has no idea that there are options out there, that they know, hey, there's an option out there. Well, at the same time, does it medicalize those who maybe are like, oh yeah, I feel sad sometimes, I must have depression, and now all of a sudden you're on an SSRI. The professional needs to be that help, that support, using their knowledge to provide appropriate guidance, appropriate treatment, and no doubt there is a huge impact that we look at when we look at social media. I just sort of think that anyone can almost go anywhere at any point in time through their phone. And I think, again, back to when I was growing up as a kid, if I wanted to go to a really bad neighborhood, well, I would have to take the subway to the ferry to the subway. Maybe I only needed to take a sub. There were probably some neighborhoods on Staten Island that weren't so great either, but nonetheless, I needed to actually go to the location. Social media, there's no need to. It's immediate, it's instantaneous, it's right there. I mean, heck, the internet, not even social media, it's right there. And then the social media, hey, as a kid, if I would go to school and I would have some trouble at school, well, I got to go home. I got to be away from it. I got to be in the sanctity of my home with my friends and my family and such, and I could process these issues and talk about them. Well, social media, everything is everywhere, every time, and every minute, and every day, and things live forever, and that's a real challenge. It's as humans, we need pauses, we need breaks, we need time to think. And I think, unfortunately, it becomes harder and harder when things are moving so fast. The attention is constantly there. And granted, maybe it's my introverted predisposition that has a natural desire for maybe less of that. At the same time, I also recognize there are benefits to some of these things as well. And I suppose it's like anything else, right? One has to. We need to be mindful and cognizant of it. And we also need to make sure that we're helping to protect our kids and not letting them just sort of run rampant. And I even think of it with my own children and YouTube and such. Wow, yeah, maybe the YouTube program they're watching isn't so bad, but the commercials are horrendous, and that's a challenge and a problem. So I mean, there's so many aspects where how do we make sure that the cultural challenges that are out there aren't necessarily just sort of right there on a plate before our kids, before ourselves, and that's important. We've got to use discretion. We've got to be aware that there's an impact that we need to have. And so, certainly, as a psychiatrist, as a father, I think there are important barriers and gates that we need to help put up on the social media content, on these other influences that come in. And it's not necessarily anything that Do No Harm has focused on in any way, shape, or form. Those are more so my own thoughts as a psychiatrist, and again, just as someone who's living through this space and trying to understand my own environment and do what's right by my kids to make sure that they're growing up in a healthy environment and not that they're living in this awful environment because I'm giving them access to immediately go to whatever dark space on the web or whatever place it might be that unfortunately it could have such a negative influence. It's important for us to say, hey, no, let's create that healthy environment so we can allow children to grow up in an environment where they are nurtured and not tormented by so much of what might be out there.
Amazing. It seems that where children are losing their childhood, right? When I was a kid, I'd say, "Mom, I'm going to ride my bike," and I'd go with my friends, and we would ride for hours and hours until
Yep.
the sun was going down, and then we'd come home. It was they can't. Parents are so stressed out. They're giving these devices to their toddlers
Yeah.
to
Yeah.
entertain them, and then it just gets worse and worse and worse. By the time they're like 9, 10, 11 years old, they're like fully addicted to their
Yeah.
devices. It's
And
frightening.
and much as you said, that relationship that you had with your friends, to see them, to touch them, to be able to connect at that level, there's something to be said about that. Yeah, I mean, this is great that we're able to do a
Yeah.
Zoom podcast. Like, this is wonderful. So the
Well,
technology can be
if you were
beneficial.
closer by, I'd
But
actually
but
drive
but it
over to
would
your place and we'd do it in person.
exactly. Exactly. And what a more and the fact that we were able to meet in person was so meaningful.
Yes.
And that just allows that connection to grow. Yeah, when a
Just the
kid
shake of the
doesn't
hand, just that little
exactly.
thing.
Exactly. Yep. It's so, and that's oftentimes I recall as a psychiatrist, I would come around with my stethoscope because I felt that it was important for me to not just assess the mind, again, to treat the whole person, but even the idea of touch, of being able to listen to one's heart or lungs. There's a connection there, and that human connection is just so important for us to be that, again, that compassionate person, and to hear people, literally hear them in for who they are.
Wonderful. Do No Harm has filed grievances against race-based programs like those at the University of Connecticut. Why do you believe these programs undermine equality in healthcare? And what alternatives would you propose to ensure underrepresented groups have access to medical opportunities?
It's a great question, and certainly, for many of the schools that we've seen is in the case of Connecticut and others, that there are at times these externships that might be offered to individuals in their third or fourth year, typically their fourth year of medical school, where effectively one is allowed to audition at the desired location because, hey, that's the place I want to get my residency at. So I'll try to get this externship and I will be there. And if I perform well and everyone likes me, well, hey, you've developed a relationship with the folks who are there. You'll probably be ranked higher to get in because you've effectively done really well in your job interview. The converse can happen as well. You could really mess it up and get ranked very low or not ranked at all. But again, obviously the intent is that folks are going in with the right mindset. But what we've seen is that some of these programs are restricted based on race and or ethnicity, and that's a problem because it is, well, for one, in terms of just looking at the law, it's a problem, but also from just the aspect of there are many different folks of many different stripes and many different backgrounds who may seek those opportunities, and so why are we now using identity politics to sort of select who gets a spot and who doesn't get a spot versus actually allowing merit to guide? And again, this sort of gets back to the challenge that we have. If you can't even tell if the person was excellent or not in their first year, their second year, on their exams, it becomes hard for programs to truly differentiate between, hey, who do we want based on merit and not? And so when we see scholarships that are just focused on race, focused on identity politics, it's a problem. We envision a system again where merit is driving the just our ability to produce excellent physicians and to have the very best and brightest. And again, for folks who want quality care as patients, we all want that very best doctor. And that frankly, I mean, it begins even before you even apply to medical school. So it is just so important. And I've worked with many folks of again different races, certainly of different creeds, and many wonderful providers who are out there. And I think it's just so important that we make sure that those providers who have clearly have the merit, have earned it, that it's clear that, hey, you know what, they're there because of the merit. They're not there because of their race or some other reason. That they are there because they earn that spot, and we shouldn't treat them in any other way. They have earned their right to practice in whatever clinical area of medicine it might be. So I think it's so important for those reasons, and then likewise I think it's also important that as part of the medical school experience that the accreditors ensure that medical schools are doing the right thing. And unfortunately, one of the things that we've seen in this country is we've seen accreditors who give the ability of these medical schools to accredit them so that folks can go on, because you need that in order to get your license that you've graduated from an accredited school. We've seen them impose an ideology. And now, granted, change has been made. The president here had an executive order to make very clear that education needs to focus on merit and accreditors need to focus on merit. But even the content of what is being taught, I think there's a real question as to, well, what are students learning within medical school? And again, that gets back to this question of gender medicine, where we've had officials in Florida who've questioned the liaison committee for medical education, the accreditor of medical schools, and said, well, hey, where were you guys? Were you guys sort of sleeping at the wheel in terms of allowing folks to do gender surgeries on kids? Like, what's going on here? How do your accreditation standards ensure that we're not doing care that isn't evidence-based? How do you ensure that? And so that question is out there to LCME and such, and that's an important question for us to ask. So I also think the other key part is what happens even before medical school and before college and before, when one is starting out within the education system, whether they're in kindergarten or first grade or second grade. Do we have opportunities that are out there that allow for individuals? Do we have schools that really educate? And again, it's not necessarily an issue that Do No Harm focuses on, as we're focused on the medical side of things, but the education system is critical, and there are parts where we're failing our students, where we're failing kids. We're not allowing them to really learn the reading, writing, arithmetic, and instead, we focused on the politics and have pushed that. And so there's a lot of work to be done there as well to ensure that folks have opportunity through education, through knowledge, through ability, and I think there's a lot of work that needs to be done in those very early years before we're even getting to the point of looking at, hey, I'm applying to medical school or not. So there's much work to be done, but ultimately, as we look to physicians, if we allow excellence to be our guide. I think when we call people to be excellent, we'll see folks put that competitive spirit out there. They'll strive to work harder. They'll learn more. They'll be better, and ultimately, we'll be having excellent physicians to provide excellent care. And frankly, in some respects, we know this driver. We know that students who do better on the MCAT tend to perform better in medical school, and those who do better in medical school tend to do better as residents, and those who do better as residents, and one study actually looked at how residents did on their board exams, that those who did better on their board exams actually have better outcomes when you look at Medicare data in terms of outcomes to Medicare beneficiaries. So, there's a connection here that merit does matter in the outcomes that we look at for patients. And if we're going to be part of a healing profession, we've got to make sure that we're doing the very best for patients, and that make sure that it requires us to make sure that the workforce is the very best to care for those patients.
Well, thank God that success leaves a trail. You're right about that. But it kind of points to a broader issue with the institutions and education being captured by these collectivist ideologies rather than, sort of the foundational American principles, individual rights and responsibilities.
I think there's a lot to be said for that, and yeah, there's much work to be done, and I know the choices that people make in terms of making sure that their children are going to the right school. That's an important choice, and again, as a parent, that's one that my wife and I have made with great deliberation to ensure that we are providing that framework. I mean, heck, if someone is spending 8 hours a day outside in the care of others, you really want to make sure that you're getting again the very best from those others, and not being indoctrinated for 8 hours in things that will come back to hurt them, and unfortunately not educate folks in any of the key factors that are needed to really be successful in the world, and just to be a good human being, and to be a part of civilized society, so that again we can live in this great country here that our founders did found for us. And so there's a real responsibility to that. And I think I went to UVA, so I suppose it's hard to go without talking about Mr. Jefferson. But the idea of how important that educated populace is to the future of preserving civilization and preserving the incredible ability and what civilization has been able to achieve as a result of so much of what these founding principles have allowed us to achieve.
Very well said. Looking ahead, what reforms do you think are essential to restore merit and excellence in American medicine? And that goes for the rest of the world, I'm sure. How can policymakers, educators, and practitioners collaborate to achieve this?
Yeah. Well, I think the accreditation piece is a really important one, because if the accreditors are setting the appropriate standards, well, then that influences all of the medical schools and such within that, or the residency programs, depending on what accreditor we're looking at specifically. And that goes not just within medicine. I mean, that could apply to psychology, to social work, to nursing. It's so important that these standards set the right principles forth, so that schools are operating within the right framework, and that we're not detouring them in other directions. And that might entail a need for competition. It might entail that maybe LCME needs to have another MD accreditor out there to make sure that it's doing the right thing. And these are easier said than done. There's lots of work that needs to be done to drive that, but that's important, and that's something that, again, policymakers, those who desire to form new accrediting bodies, can work on, and certainly we've seen evidence of that coming out of Florida and other states that have formed a compact related to accreditation of colleges and such. So there's hope that folks are looking towards a way of providing education that is focused on educating, and having accreditors that do that. So I think that's an important factor. I think it's also important that we continue to communicate effectively with the people, and to help them understand. Because what we found, and what we really aim to do at Do No Harm, is we aim to focus our efforts on research in addition to the education that we provide. And so the research piece is just so critical, because it allows us to speak speak with authority. And so we can look at studies that might say X, Y, and Z and recognize, well, actually, that study doesn't say anything of the sort. We have a study coming out in a couple of weeks that one of our director of research did on pain studies, and this came from actually the Association of American Medical Colleges when it filed a brief in relation to the Students for Fair Admission case that was at the Supreme Court a few years back. Well, they were arguing that, hey, we need to have holistic review. We need to continue to look at race. We can't do that. Well, the Supreme Court ultimately said, well, no, you can't have race conscious admission. So it said no effectively to the AAMC. But what the AAMC did in its brief to argue for sort of race conscious admissions and such was it was quoting pain studies. And so we've decided, well, hey, let's look at those studies that they quoted. And what we found is that those studies don't even really reflect what is said in the amicus brief that was written by AMC, along with 45 or so other medical societies. So I won't spoil it. It's coming out in a couple of weeks, but I think it's stuff like that that's so important. And we've done similar work on racial concordance. So this idea that black patients need black doctors. Well, I suppose you could also say, well, then do white patients need white doctors? And this is crazy. That's segregation. We don't want to go back to a past that was awful and not right. We need to move forward. And black patients and white patients, they want excellent doctors. There's no color categorization whatsoever. And so we've got to change that. And so there's a study out there that many people quote to argue for this idea of racial concordance. And it comes from Florida. It looks at babies that were born and finding that, well, black doctors seem to have better care and better mortality outcomes for black babies than white doctors. Well, the reality is that when you look at that study, they didn't take into account very low birth weight babies. So these are babies that are often taken care of by neonatologists and such. And when you look at very low birth weight babies, and if you actually control for that variable, you find that there's no difference in whether the baby has a white doctor or a black doctor. And so the study is just completely erroneous in its conclusions, yet it's been cited, I don't know, 700-800 times. And there actually is a study that counters it that was published by the same journal that has maybe been published only 10 or so times, or cited, I should say, 10 or so times. And that's a real problem as to these studies come out, they get the headlines, but yet, when you actually question the data, and in fact, the Manhattan Institute was the institute that had specifically done this. They asked those original researchers, hey, can you share your data with us? They controlled for very low birth weight babies, and they found that, hey, there's actually really no effect here. But that doesn't get repeated in the press. That's not the hot headline that folks, and again, this study gets cited over and over and over, and it's unfortunate because it not only gets cited in the media, it also gets cited by Supreme Court justices
Oh God.
and it gets echoed repeatedly. So it's important for us at Do No Harm to look at this, to provide the observation. It was a couple of our folks at Do No Harm who had recognized that, well, hey, wait a second, you guys didn't control for very low birth weight babies, and it was great that the Manhattan Institute sort of jumped on that and got the data and did that. But it's those kind of questionings, that kind of debunking that needs to be done because the narrative just isn't there. And in fact, if you look at systematic reviews that study the claim that, okay, well, are there better outcomes if black patients have black doctors? Well, the reality is that 5 out of 6 of the systematic reviews show, well, there are no better outcomes. So there is one out there that does suggest maybe there's some relationship in communication, but I would argue that there's some methodological flaws to the studies that they selected versus the studies they didn't select. But either way, 5 out of 6, there's no benefit to this idea of racial concordance. So yet we continue to harp on it. And in fact, that's one of the reasons that's often offered as to, hey, this is why we need to focus on race-based admissions as opposed to merit-based admissions. And it's just flawed. It's a flawed concept. And again, if one looks at it for what it truly is, do we really want segregation? And I would think that the vast majority of people would say, heck no, we don't want that at all. We want good quality physicians treating anybody, and we want to focus on that. We don't care what our physician looks like. We just care about the quality of their ability to provide medical care to us. So there's a lot of work to continue to be done to debunk this because, frankly, I think the people are perhaps further than where medicine is. Medicine, unfortunately, it's hard to publish sort of contrary views within medical journals. I sent a letter to the editor to the American Academy of Neurology. Well, I should say their journal Neurology. They had published a roadmap to health equity, which is filled with all of these DEI concepts. And so I sent a letter to the editor, which is restricted to 200 words, and I got back sort of a six-sided questions, which have multiple questions within them, probably more questions than you've asked me thus far today, about my 200-word little tiny letter that I'm confined to, and this is sort of the hurdles that one has to go through. Now, granted, I understand an academic journal should ask questions. I have no problem with that, but I wonder if the same level of scrutiny would have been given to a letter that was supportive of the roadmap that was offered, or if this is unique to the fact that, well, wait a second, here's a contrary view. We need to put the walls up because we don't want to hear those contrary views. And that's something we saw it as well at the American Academy of Child and Adolescent Psychiatry as Do No Harm. We applied to be an exhibitor there to their annual meeting, which was this past October. And once they found out who we were, i.e., they found out that we thought, you know what, kids should actually be treated with therapy and not be forced into a medicalized model. Once they found that out, they said, well, no, you can't present, you can't be an exhibitor. We need to leave that to the scientific program if we're going to have any sort of debate. Well, I thought to myself, well, if you extrapolated that sort of logic, well, then you shouldn't have anybody exhibit, because shouldn't pharmaceuticals also be subject to the scientific portion and then not exhibit because they're promoting a concept? Well, that wouldn't that logic certainly doesn't fly with the folks that are taking the money at the American Academy of Child and Adolescent Psychiatry. So yeah, we were denied, and so this is part of the problem. We need to continue the efforts to continue to beat on the doors of academia, to beat on the doors of medical society. We need to get involved in medical societies as physicians to make sure that we have the voice of reason heard within these societies, and really aim to show the activists that, hey, you know what, you're no longer in charge. We need new common sense physicians, and unfortunately, many physicians have just been so disheartened by their medical society, and I get it. Much as the public has been, they've been disheartened. They've walked with their feet, and so you get an organization like the American Medical Association that has maybe 15% of doctors. Again, these are post-residency physicians, attending physicians who are actually members. So the vast majority have no membership with the American Medical Association, or you get the American Psychiatric Association, which has 40,000 members, but when you look at their election, only I think about 5,000 or maybe even less, 4,000 voted in their last election. They complain about the voting in the United States election, but they don't look at their own election at these low participation rates. So the ironies are plenty, but there's a lot of work to be done within medicine, and it's we see these as 80-20 issues when we look to the public, but unfortunately, there's a lot of work to be done within the halls of medicine to get some changes to come about and to bring common sense back to medicine.
Common sense is extraordinarily uncommon, it seems. It seems quite rare, but it's a frightening world when our Supreme Court justices and the heads of these boards and the heads of these journals seem to get their evidence from CNN and MSNBC and a Blue Sky post or something. I don't know. I mean, it's amazing to me. So let's wrap it up. What's one piece of advice that you'd give to aspiring medical students or young doctors navigating today's polarized healthcare environment? And is there anything else you'd like to share with the audience?
Well, I would certainly welcome folks to join Do No Harm. I think one of the things is knowing that there are other people out there who recognize the insanity that you're going through. And I also recognize that if you're a medical student or a resident, do your best. Focus on studying, learn everything that you can learn, aspire to excellence. Even if it gets you a P, aspire to excellence, because you want to be the best. You allow your self-driving motivation to continue to steer your ship, and don't be distracted by the nonsense that's out there. I also recognize that it can be really hard to speak up. And I get it. I get it. I mean, I even look at my own position where, when that insurance company came and said, hey, you know what, you're changing the pronouns. Yeah, I really grit my teeth, and it was rough, but we changed the pronouns because we wanted to make sure that we could have a program that allowed us to care for folks who were struggling with depression, suicidal ideation. Again, having nothing to do with gender dysphoria, but just focused on caring for individuals. I get it. it struck me so dearly that I felt like I needed to do something, and being part of Do No Harm has just been a tremendous benefit in that regard. So I would certainly offer that, in terms of, be a member. Understand that there are others out there who share your concerns. We're in this together. We're going to continue to work to change medicine for the better. And your voice is welcome, and we ask you to be part of us. But again, to focus on just being excellent, being that good quality physician. And there's so much to be said for just being joyful in life, and to appreciate the patience, the gifts that you've been given, and to use those talents for good, and to know that medicine is a wonderful profession. I mean, as much as all of the muck that we've spoken about, it really is such a privilege to be able to connect with a patient, to have someone, again, that trusts you, to share things with you they might not tell their spouse, they might not tell their children, their parents, whoever it might be. To be able to be in such a relationship with somebody, to help them, to guide them, and to also be humble and to learn from them as well, to understand, because there is so much about this human experience that we share in common, and how we can, again, journey together. It's a beautiful thing. It's a beautiful part of medicine, and again, very much a privilege to be able to have that connection, that relationship with folks. So I would certainly, advise, hey, don't give up, don't lose sight, recognize there are others out there, and recognize that, yeah, you might not be able to say what you exactly want to say at the moment, and that's okay. But just focus on being excellent. Focus on doing what's right for the patient that is before you. And I think when we focus on that, when we truly have patient-centered care that allows us to incorporate our full complex of ethical principles, we will be providing exceptional care, and people will recognize that, and they'll ask, "Well, hey, what's it about you that makes you different?" And it may very well be, again, that personal experience that you bring, your faith that you bring, whatever it is that you bring to the experience that allows you to just shine with just such brightness, that will be seen. Others will see it, they will recognize it, and they will want it, and they will want to know, what is it about you? Why are you not burned out by this crazy field? Like, what is it about you that makes you different? And if you can really be that light, that salt, whatever it might be, for me, that's such an important message, and it's so important to be doing this work. And again, it's different strokes for different folks as to where we are in our advocacy. For me, I certainly feel like it's a blessing to be at an organization like Do No Harm, and to be doing this work on behalf of many physicians who feel very much the same way. But likewise, there are many other ways of doing this, and whether, again, through membership. We have fellows with our organization, but most importantly, doing it within the context of the doctor-patient relationship, by just being that truly good doctor that recognizes the morality of our profession and exercises that morality and judgment in doing the right thing for patients.
Well, God bless you, Kurt. Wonderful advice. I just want to thank all the viewers and listeners, and I just want to thank you again, Kurt. That was wonderful.
I appreciate it, Mike. Thank you so much for having me.